Okay, welcome all to our third session in our longest day webinar series. We are so excited as Synergy HomeCare to be able to participate in the longest day event with Alzheimer's, and particularly proud to be part of the national team for the Walk to End Alzheimer's. My name is Carla Sutter, and I am the Director of Operations at Synergy HomeCare. We are a national home care organization that has offices around the country providing assistance to clients whose lives have changed due to age or illness. And on this third session of this webinar, we will be talking about understanding the stages of Alzheimer's and best ways to care for individuals at home. I've seen this quote, and I've really, it's impacted me over my years as a social worker and who's worked in the healthcare industry for over 25 years working with families and clients. And it says that anyone who comes in contact with an individual with Alzheimer's disease or related dementia has the ability to impact that person either positively or negatively. I think that this is so true not only for Alzheimer's, but for really every person that we connect with and meet in our lives, but particularly true for those living with Alzheimer's or dementia who require and deserve having that individual approach and connection with those they meet. I am a big believer that with any diagnosis and for individuals that when we have met and are working with someone with that diagnosis, we have met and are working with that one person with that diagnosis, because each of us, as we bring who we have been in our lifetime, the experiences that have collected and we have collected, that is what we bring to the place that we stand today, no matter what diagnosis or disease that we are living with in that moment. My hope that at the end of this hour is that you will have a better understanding of the diagnosis of Alzheimer's and some of the stages, and we're not going to be doing this in a very clinical way, but to give an overview that hopefully is easy for all to understand. And I know we have a combination of both family members as well as professionals who are attending these sessions, and I think that the hope is that each one who comes to any of the sessions will come out of it with what they are needing and adding to their knowledge that they already have. My hope is that we will be able to, with the information, visit a little bit the culture of dementia because it is its own unique place that people find themselves. We're going to talk about communication, both verbal and nonverbal, behavior issues that do occur, the different ways to approach individuals, the day-to-day living that both caregivers and those living with this illness are facing, technology and environmental changes, and the grief and loss that is unique in several ways to those living with this disease. So Alzheimer's is a chronic and persistent disorder caused by a brain disease, and this is the definition for dementia, which Alzheimer's is a part of, or injury that produces a decline in memory and intellect from some previously higher level of functioning, severe enough to interfere with everyday life. I think the most important thing, and I think that over the last years, we individually as well as the healthcare community recognizes that dementia is not normal aging, that it is not a part of aging, that certainly as we age, we have a higher percentage of risk to having dementia and in any one of its forms, but that it is not a normal part of aging, which I think is something that many of us certainly are concerned about and fear as we look towards our own aging. What is unique is that when we talk about dementia, it really is an umbrella terminology, and that these are just some of the different diagnoses that are under the dementia umbrella, which is just a combination of symptoms, which could be due to a brain tumor. There is frontal temporal disease, vascular dementia, Lewy body disease, and of course Alzheimer's disease, which has the highest percentage of those who are impacted by this form of dementia. 70% of dementia is Alzheimer's related. Vascular dementia is 17%, and the other dementias, including several of the other ones that I talked about, make up the remaining. And this is for those living who are 71 years and older with diagnosis. It's important to understand because, again, I think the community at large and publications and when we read, we kind of have terms thrown out, and I think it's important for all of us, and certainly most of you on this call are unfortunately all too knowledgeable about the definitions, the differences, and the similarities, but to just kind of go over this, that dementia is a set of symptoms. It can include memory loss, behavior changes, and personality changes. It may be reversible. There are many different diseases that can cause dementia. It may have a physical or mental cause, including dehydration, infection, thyroid disease, diabetes, medications, and psychiatric issues. And risk does increase with age, with dementia as well. With Alzheimer's disease, the most common form of dementia, between 60 and 80% of all dementia cases, it is progressive, degenerative, and an irreversible disease. It, again, is not a normal part of aging, and over 5.4 million Americans have Alzheimer's. 1 out of 8 people over the age of 65 and older, and nearly 1 out of 2 over the age of 85. So again, while it is not a normal part of aging, it certainly increases with age. Alzheimer's disease, again, is the most common form of dementia, and symptoms of Alzheimer's disease can include a variety of stages. In the early stages, it may include difficulty remembering names and recent events, and we're going to go through these in much greater detail. Mid-stage symptoms may include deficits that impact language and visuospatial function, and in later stages, it includes impaired judgment, confusion, difficulty walking, talking, and swallowing. Again, while Alzheimer's disease and vascular dementia account for the vast majority of dementia cases, there are other forms of dementia, some that have similar symptomology and others that have unique symptoms unto themselves. We are going to be in this session talking really about Alzheimer's, but again, as you listen, if you are living with someone who may have a form of dementia from any one of these, there's certainly going to be aspects that will make sense, that you will recognize, and things that you can do to help manage and minimize some of the symptoms of what you're experiencing. Again, Lewy body, mixed dementia, Parkinson's, which many individuals, although not all, will have a form of dementia as the disease progresses. Frontotemporal dementia, Creutzfeldt-Jakob disease, and normal pressure hydrocephalus. Again, there are many different reasons and for memory loss, not all related to dementia conditions, brain tumors, traumatic brain injuries, hyperthyroidism, seizure, migraine, and Huntington's disease, as well as things such as dehydration, medication. So there's a variety of reasons for memory loss. It is why it is so important that with any change in someone's functioning, change in someone's recognition, that you want to always connect with a medical clinic. I think for many, as they start to experience memory loss, there is such a fear of what the diagnosis will be that we tend to kind of put off being seen, when in fact there are some things that could be managed much earlier in its stages, and hopefully as we move towards a better understanding of all the different forms of dementia and memory disorders, that people will feel more comfortable and confident that early diagnosis is going to be better treatment. So as we think about Alzheimer's disease, it does begin in the hippocampus, and that is actually where memories are formed. It does move throughout the brain, and it moves to the temporal lobes, which organizes the sensory input and language, and can have auditory and visual hallucinations. I think the most important reason for kind of understanding where in the brain one is impacted and what are the areas that are what happens in those areas in a healthy brain, and then what changes with the onset of Alzheimer's, is more in terms of how we then approach individuals and how we set up services and programs, and how we communicate so that we are doing our best to ensure the most understanding. So even for those of us who may not be clinical in nature and need to really kind of understand the full idea of how it is working, it's important to understand what is impacted, so that's the area that we can approach in the ways that are necessary. The parietal lobes control touch and pain and spatial awareness. It enables our eyes and our limbs to recognize objects. I think understanding that gives us a better sense of when people begin to have symptoms that are related to that part of the brain. It then allows us to know how best to manage that. The frontal lobes manage the retrieval of formed memories and where judgment and reason are housed. So I think it's often really difficult to kind of grasp and understand what happens to information when you have Alzheimer's. And this was something that I just recently found, and it really, even for all the years that I've worked with clients who are living with Alzheimer's, and my work in hospice, working with clients and families who were at the end stages, this was probably the best way that I've experienced what it's all about and how it connects. And it's done in such a way that has nothing to do with pictures of the brain. It's all about track systems. So let's say the people in Phoenix do not know what date it is. They ask the people in Scottsdale, and they tell them that today is Monday. In the brain of a person without Alzheimer's disease, the train, or that thought, goes from the point of entry to where a brain stores that memory. In the brain of a person with Alzheimer's disease, there are neurofibrillary tangles, which are twisted filaments that occur as abnormal structures in the brain, blocking that memory storage. So we can think of those tangles as the track systems, and that these are tracks that are not connected to anything. There's not a straight line. It's all crooked and tracks that the train can't connect over. Because of that, it takes much longer for the information to get from point A to point B in the brain when the track is twisted. There are also plaques in the brain of a person with Alzheimer's disease, and these are dead and dying nerve terminals that cluster around abnormal fragments of what's called amyloid proteins and interfere with the transmission of impulses. So again, if we think about all of this outside of our brain, which the language itself becomes overwhelming and confusing, and really think about it as this track system and this complex way of transporting information from one locale to another, that's really the same thing if we just think about it as that track system. So now the thought is traveling all over the brain, taking much longer to get where it needs to go, and has to push through the plaques that slow it down, and even more in some cases will stop the thought completely. Acetylcholine production is decreased as well in the brain of a person with Alzheimer's disease, which makes nerve receptors less receptive to impulses. This is like the train that's carrying the thought through the brain, gradually running out of fuel. There's also a degeneration of the hippocampus, and this is the area of the brain responsible for learning and new memories. And this is like the conductor getting off the train, and now the train has no one to give it direction. So let's think about where the stages are. And as we move towards this, there's a lot of different ways that staging happens. In some books and in some clinics, they talk about mid, early, moderate, mid, severe, late stage. In some, they number it from 1 to 5. It's really, for what I'm talking about today, I think the most important is just understanding what are the difficulties that someone in these different places, and you're able to probably think about those in your life, are, and what we can do to improve their functioning and manage symptoms better and make their quality of life higher. There is a new thinking that may lead to some different staging that includes what's called a preclinical Alzheimer's disease, where there's biomarker changes, so things that we can eventually test for, but no necessarily impairment, so that we're not seeing it happening on the outside, but things may be happening at that time internally. And there will be some decisions when we get closer to understanding that as to how and when people want to be diagnosed and what they want to know, and much of that will be dependent on what kind of treatments we can offer. So the first stage, and this is often happens for several years prior to even having the actual diagnosis. But what often happens is that at the point that the diagnosis is made and people start looking back, a lot of the examples that I'm going to talk about are things that people can say, yep, either I was experiencing that or I recognize that someone in my life was experiencing that. So some of the symptoms could be a recent memory loss that begins to affect job performance. What were they just told to do? Confusion about places, getting lost on the way to work. Loses spontaneity, just that zest for life. It seems to be almost that candle dimming a little bit, and more difficulty. And it's hard to know if that is from the focus that's happening to try to keep other things together, if it's part of the disease progression, etc. Mood, personality changes. Patient becomes anxious about symptoms, avoids people. And again, this may be because they're recognizing that something is different, and they're concerned that the more they're out in public places, the more that they will kind of be quote-unquote found out. Someone has poor judgment, maybe making bad decisions. Maybe someone who was very conservative with finances is now starting to dabble in day trading or doing more things that are much higher risk with things, and making poor decisions about that. Taking longer with routine chores, trouble handling money, paying bills, forgetting which bills are paid and phone numbers that are called frequently, losing things and forgetting the grocery list, arriving at the wrong time or place or constantly rechecking the calendar, being withdrawn, disinterested, someone who spends all day making dinner and then forgets to serve several courses. Now, this is, I think we often can see ourselves in several of these, and we need to recognize that this is over a period of time. This isn't on the day that you have 3 places to be at the same time, or you're worried about, your adult child or a grandchild, or you haven't been feeling well and your focus has been clouded by, some over-the-counter meds. This is on an ongoing, that we're seeing this on a regular basis. Someone who pays his bills 3 times over or doesn't pay them for several months. The second stage is really the longest, depending on how early diagnosis happens, and this can last for 2 to 10 years, depending on the individual, with varying degree of impact. But increasing memory loss and confusion, problem recognizing close friends and family, repetitive statements, restlessness, especially in the late afternoon and at night, something we know as sundowning, perceptual motor problems, difficulty finding the right words and making up stories to fill in the blanks, problems with reading and writing and numbers, gaining and then losing weight, which may be an impact of the kind of forgetting about eating, the hunger signals, and just all the steps that have to be taken, not only in just the preparation of food, but in the actual process of eating. An increasing need for more supervision. Sleeping more often, awaking frequently at night, motor problems and difficulty getting into a chair, setting a table for a meal. And as we talked about how it moves through the different parts of the brain, you can recognize how these changes begin to happen because, again, the different parts of the brain are starting to be impacted more intensely. Difficulty finding the right word. Language is both expressive and receptive. So aphasia is a language problem. They can verbalize often, but it doesn't mean they understand, or they may understand, but they can't name it. You know, there's some individuals that you can show a pen to, and they could say that it's a pen, but if you ask what it's used for, they're not able to explain that. Others can explain what it is to write with, but they couldn't name it. Maybe loss of an impulse control, sloppier table manners. You may see somebody who's always been dressed very fastidiously and now is wearing clothes that they never would be wearing out in public. Could be a huge appetite for junk food and other people's food, or forget when the last meal was eaten. So many different aspects here, and again, it's during this stage that we're often seeing the hardest struggle in terms of finding ways to manage behaviors, managing the family setting, figuring out how to manage the environment because of these. And then the late stage, which can be over 1 to 3 years. And again, these are rough estimates based on the research that's been done and kind of a shifting depending on how many stages you put in between. This is where they're not able to recognize not only the family but themselves, for instance, in a mirror. Losing weight, even with a good diet. Little capacity for self-care, both in a physical way, and earlier they've lost that ability to kind of even understand that they need to do this. Much more difficulty communicating with words if they're even utilizing words. May put anything in their mouth or touch anything, again, not able to kind of understand hot or cold or those type of items. Can't control both bowel or bladder. Maybe having some seizures, difficulty with swallowing, some infections, both pneumonias as well as skin infections, all of those items. If we think about the stages of Alzheimer's disease, there is a way to kind of think about comparatively to levels, cognitive levels, and what kind of activities children are doing. And I don't use this slide, and I want to be very clear as talking about this in a way to infantilize, to make childlike. But I think it's a good slide in terms of allowing us in our own mind to recognize what that looks like. I think we all have a kind of a innate sense of what it's like for a, what a 5-year-old to an 11-year-old can do, or 2 to 4-year-old, or an 18-month-old, or a newborn. I think we have a innate sense of what is expected at that level and what we can do to assist. And that's really the best reasoning for kind of putting up a slide like this, is to give it a name and I think a visual, better understanding of what is happening at that time. So again, in the early stage, it could be someone's cognitive level of an 11 to 5-year-old. The middle, 4 to 2, late stage cognitive level of an 18-month to 1-month-old, and in that terminal, very terminal end stage, the more of a newborn, kind of where every aspect needs to be managed and taken care of. Culture is something that we all exists for all of us. I think we often think of culture as very related to ethnic culture, religious culture, but really each of us has numerous cultures that we exist within. Those, for instance, who work in healthcare, there's a healthcare culture, a kind of an understanding, an unwritten kind of understanding of what it's like to work in that setting. Those who participate in sports are going to have a kind of a sport culture and how you play on a team. And there truly is a culture within dementia in terms of what that's existence and some of the areas that people are experiencing. I think to visit that, we need to be present in the moment and fully attentive. We need to jump into their world when we're with them, and when we do this, we satisfy the needs sooner and won't have to repeat that process as often. We absolutely need to recognize the uniqueness of each person. We need to know something about each person, their personality, their life story. It's why in so many facilities now, not only with those who have dementia, but just our senior population, that they have really life story boxes outside of the room, because I think oftentimes the people that we are visiting or caring for may not be able to share who they have been their life. They don't have the words to express that anymore for a variety of reasons. And we want to, it's so key to understand who they have been to understand where they are today. It's one of the key things with our staff that we work with all of our caregivers on, is to not just look at someone in the moment that you walk into their home today, but who have they been, recognizing what's been important to them, what has filled them up emotionally and faith-wise and all of that. It's important that we draw out every person's remaining ability. It's so easy to recognize what they can't do, but so important to know what they can do. Help to encourage and maximize what they're still able to do, even if it shifts and changes, but we take whatever we can out from that. We need to communicate on a feeling level. When we validate their feelings, we validate them. Feelings are real for them, even if events are not. We need to assume that words and actions have meaning and try not to see them only as problem behaviors, but really it's having to investigate constantly what the hidden meanings are, because if for individuals who have difficulty finding words to express, we have to go with what the base instinct is. We need to nurture bonds. We need to have socially nourish attachments between people with dementia and caregivers, as well as among people. We need to promote interdependence, do only what the person with dementia cannot do on their own, and no more. The decline of living with dementia is compared to the growth of children, like the reversal of childhood, but both need nurturing and encouragement. It's so key, again, to recognize that every person living with Alzheimer's is still a full, whole, holistic person, and we need to treat each individual as an adult with respect, no matter what level they are at. There was a study done by the University of Kansas School of Nursing that studied the use of elder speak, otherwise known as baby talk for adults, and the study showed that those with dementia were more likely to resist care when nursing staff used elder speak. This study suggests that there's a key association between communication style and resident behaviors. So as we listen to ourselves, talk with those that we're providing care for, whether on a professional or personal level, we really need to think about our tone of voice, our way of speaking. Are we is it all about questions that we're bringing everything up at the end, and people are thinking that they have to answer something? As you may hear in my voice, I'm a native New Yorker, lived in the Midwest for many years, but can't lose the accent. And have always been very aware in my work to be, especially when I lived in Minnesota, to not have that as harsh of the New York accent. It's not always easy to change at all, but to definitely, particularly when I'm working with clients, to soften my voice, to speak slower than I would as a typical New Yorker, because communication style is so key. We need to think about our own reactions to different communication styles when someone speaks to us, and how we either bristle or warmly embrace what they're doing. We can easily demoralize by our approach. If we say, don't you remember what I just told you, and then have a big sigh afterwards, even if we don't recognize it, that individual may absolutely recognize that impatience, that frustration, without understanding the words, but just by the approach. We often find ourselves also outpacing their processing. We don't want to work so fast that they can't catch up. There was a beautiful study that was done at a nursing home and they videotaped different interactions in rooms with people with dementia and Alzheimer's. And there was a husband and wife, and the wife would come in and visit, and they would, hold hands, and the husband really could not communicate very much, and she would share some stories and all of that. And at the end, she said, I love you. And the gentleman in the video, as we watched, did not respond. And, you could just see the hurt and struggle and grief that this wife had as she walked out of the room. But what the videotape showed is that several minutes later, after she had already left, is you could hear the husband say, I love you too. And what it reminds us is, again, that we often outpace their process, that we would expect that response is immediate, but we have to remember that we often have to wait. And what a beautiful reminder of that in this particular situation. Effective communication is the key to enhancing the quality of life for an individual living with Alzheimer's and dementia, and for improving our efforts to care and interact with them. Even from an early stage, individuals can experience problems with language, difficulty following a conversation, word finding difficulty, longer to compute and respond, maybe using language they've never used before, cursing or inappropriate language that may be derogatory. They may rely on nonverbal gestures more. They may confabulate, which is, kind of making up things just to kind of fill in the space. The other piece is that they have often found that those individuals who have higher kind of social functioning kind of positions, where they had to do a lot of social interaction, where there was a lot of kind of social politics occurring, is that oftentimes they're able to, for a longer period of time, kind of quote-unquote fake it, and unless you really know that person, unless you dig into what they're saying or question it, you're going to believe that they have more capability than they do. And actually saw that when I had a client that we had a neuropsychology assessment from, and it really talked about that because of his position, and he was a lawyer and a judge, and he, again, had a very high kind of emotional IQ and social kind of political capabilities. He was able to fake a lot of it until it got to a place where, it was most people who, even those who didn't know him, knew there was something wrong. Research shows that only 7% of communication is verbal, and 38% is the tone of voice, 55% is nonverbal. And so for the person with Alzheimer's, the unspoken language of the body and the tone of the voice becomes more important than the words we actually use. Nonverbal communication really is the process of sending and receiving wordless messages by means of facial expression, gazes, gestures, postures, and tone of voice. It also includes aromas, pictures, signs, signals, and cues. And it can include the written word. Again, think about for yourself when communication is happening, how do you best respond? If you are someone who right now is just listening to this webinar by phone because you don't have access to a computer, are you wishing that you could see the written word versus just hearing it in my voice? For those of you who are watching and have the computer available, are you more reading ahead and reading it versus listening to what I am saying verbally? So again, we have to kind of know and understand that and think back to the people that we're caring for and ask questions of how they best communicated information. Something that's really easy to try to remember when it comes to communication is the the acronym for person. P standing for positive approach, pleasant, personable, patient. E for empathy, energetic, engaging. R, respect for them as an individual. S could mean sincerity in our approach, simplify, smile. O, openness. And N, a non-judgmental attitude, and nice. And when I say the non-judgmental attitude, that really is more about, I think what happens is that frustration that builds up in terms of having to work so hard to try to get a message across or try to get a reaction, that just by our own nature, we're exhausted and we tend to let down some of our walls about showing what we're feeling. So always remember and never forget basic principles that can guide us in our care. And again, this is both as professionals as well as family members, that the individual isn't trying to be difficult. Everyone is unique. The reality of the person with dementia is different from your reality. So we need to listen differently to what that client is telling us and reading between the lines, because their approach, their perspective is very different than ours. Show that we're listening and trying to understand. Focus on the feelings and not just the facts. We need to put emphasis on what the person, again, can do and let them do it. That's very difficult, I think, sometimes, particularly in facilities where there's so much that has to occur, and the time frame to allow someone to do it at their own pace can really become kind of a detriment to the schedule, but it's so key to allow them to do as much as they are able to do. Prepare the person for what is to happen, but know the person. If someone's time capabilities is so limited and they really have no sense of time, we don't want to say and focus everything around a time frame. I'm going to come back in 3 hours, or, I'm going to come, we're going to do this in 2 days, because that doesn't mean anything to them. Instead, depending on what they can understand, maybe they watch a show that they really love, and then there's a show after that, and you can say, I'm going to come back into the room when it's time for, and then the next name of the show, and maybe they're still able to comprehend it in that way. Assume the person understands everything you say, but confirm that and monitor. Be realistic and patient. Don't argue, criticize, correct, or reason, because again, they're not understanding it in the reason why you're doing that. They only see it as being argumentative, critical, and being angry. Using distraction, where you can walk away and try again later. And if you are listening and you are part of a care team, sometimes having another member of the care team be the one who approaches afterwards. We never know why someone may connect with one person over another, and I think we often as caregivers ourselves can get our egos connected to that, and certainly as family members. And it may just be that in that moment you're reminding them of someone that they just didn't have a good time with for that day, or in the experience or the memory they're having. Keep a sense of humor, and remember, clients have sense of humor too. Don't sweat the small stuff. What you say and what they hear often don't match. And again, it's all about respect. Every behavior is a communication about the individual's needs or concerns, and we need to listen and assess always, at all times. Always be thinking about what could this be, what could they be looking at, where could this be coming from. Our approach needs to be flexible. We need to start from the beginning each time. And for instance, even if you've introduced yourself every day, you need to keep introducing yourself every day. Using a picture board so that if different caregivers are coming in, I know with our caregivers, if we have a client, we may have a calendar and we have the pictures of the different caregivers, and then we'll just put a kind of a magnet board, and each day we'll have what caregiver is coming, so that there's a visual along with a name. Smile. get to eye level or below them. There's actually been some research that shows that when we have to look up at somebody and our eyes actually kind of roll back a little bit, that it changes the way that we're able to process information. So you never want to be having the client, no matter what diagnosis, having to look up at you. First of all, there's the feeling of kind of a power differential as well. Validate what they're doing and where they're at. Distract when you need to, and avoid correcting. You being right means that they are wrong again. What could be the unmet need? Is it pain? Do they need to go to the restroom? Are they bored? Do they feel unsafe? Is there a need for attention? And is there an environmental trigger that's occurring that we need to remove? There was a article that talked about a day room at a facility, and there was some potted plants, and there was a gentleman who would continue to use the potted plants as the part of his restroom. And what they realized is, it may have been that he would go out on hikes and use the nature and what he had around him, and they were just a trigger for him. So when they removed those potted plants from the day room, they no longer had difficulty with him, and he no longer was having accidents in places that he shouldn't be, and he wasn't needing to having any kind of exposure issues. And it was just looking at the environment. And while the trees were very pretty there, it wasn't worth him having to maybe not be able to be in that room or be in that environment. So we really have to look at, again, oftentimes we set up environments to be pretty and to look nice, but it doesn't always mean that it's the best environment for somebody who may not be able to understand the reason that certain things are there. Living day to day. The changes in the brain that are occurring over the course of Alzheimer's directly impact day-to-day living and the experience of individuals and their family members. So here are some examples that the Alzheimer's Association talks about that we do as just part of our day-to-day, but we don't even recognize that, particularly as people start to have spatial-relational issues, that this can be impacted. Bathrooms that have too busy of wallpaper or curtains, and it's hard for people to then kind of see where the wall ends and begins. There was a facility years ago, one of the original memory care facilities in the Minnesota area, and one of the things they did that was unique is that, most of us arrange our bathrooms so that when you open the door, the first thing you don't see is the toilet, because it's the least, enjoyable part of what you see in a bathroom. But for someone living with Alzheimer's who may be starting to have problems with remembering what to do and when they need to go, the best thing to do is to have that visual as a constant. So all the doors opened where the first thing you saw was the toilet. In the bathrooms, they never had mirrors, because what was happening is people often could no longer recognize themselves in the mirror, and they became frightened that the person in the mirror was somebody else, and who wants to do something, your most private business in front of somebody else. So they took mirrors down. So just thinking about those little things that can so impact how people operate. If we have a plate that is a white plate and then mashed potatoes and then gravy that's kind of the same color, that not having different colors can really impact somebody's appetite and ability to kind of see it all. It just kind of all blends in together, and presentation is so important when it comes to our appetites. Having a light-colored floor with a new dark rug, maybe in front of the bathroom or a place you want them to be. Many people will associate that big dark spot as a hole, and instead of walking on it or over it, they will avoid it. So we need to be, again, aware of how we're setting up things, the colors that we're using. There's lots of resources on the internet as well as on the Alzheimer's Association website that shares kind of all of these little things. Home safety and technology enhances everyday living, and we are absolutely at the time in place to really be able to use technology to its best. helping loved ones to enhance their best days and finding resources to support them on their toughest days is really one of the mottos for Synergy Home Care, and certainly speaks to finding the resources that are going to best aid somebody. So in early stages where the person is becoming forgetful, misplacing items, getting disoriented, and maybe having more difficulty expressing themselves, this is where activities and games and puzzles that are at a level that they can manage, that they have some mastery over, doing aerobic exercise, dementia clocks and reminder devices, so things that help them not have to work so hard to remember. Having a medical alarm alert bracelet so that if they do become disoriented or lost. Using Post-it notes to label things, and maybe not just label with a word, but with a picture as to what is behind the drawer pull or the closet. In the middle stage, help is needed to continue to live independently. More monitoring is needed, often by caregivers. Bathroom and kitchen safety are really of vital importance. This may be the time where you're turning off the stove and maybe covering the burners with a big metal kind of cover. Signage, again, is so key. Dinnerware that is easily manipulated so that eating is not a difficulty. Making sure that the phone is something that they can utilize, one that has buttons, big buttons, and has maybe a picture on it that is pre-programmed to call, the daughter or the wife or the fire department with a picture, so that as they still are able to do some recognition that we're using that. Medication dispensers that alert when the med needs to be taken and has a listing so that you know if there's been a problem. And incontinence products, and there's many different incontinence products out there that can really help alert people to when they need to kind of get changed when they're having any kind of problem. So lots of things, and things that are now much more discreet than they ever used to be. In the late stages where there's more severe incapacitation and loss of verbal skills, some of the same types of things with different types of signage, and many of these same items, and additional care support. More monitoring programs, monitors that have photos, pictures on them, so that if they get up in the middle of the night, it can alert to a sound. Those type of things, so that we know where people are. We need to enhance our present space. We need to think small while remembering the big picture. From coffee pots, when I worked with a client early on, she really liked to make her own tea, but we were concerned about her using the stove, so we had a teapot that had an automatic shut-off, so that even if she forgot to shut it off, it would automatically shut off after it sat on the counter for a period of time after it kind of boiled the water, and that worked for a long time. P.O. boxes, so mail, in this actually same client, she was overwhelmed when the mail was delivered. She just didn't know what to do with it, and she would go over it, and she really got concerned. And so the family just had the mail changed to a P.O. box that they could pick up. They would bring it to the house after they had gone through it, and together they could go through just those items that needed to be, so it wasn't quite as overwhelming. Again, there's whole house monitoring where we can really see what's happening in the home and ensure that people are safe. If they at that initial point don't need caregivers for a period of time, or as an adjunct to the rest of the team. Wander guards and GPS systems, both on bracelets, things on the doors so that we know and it can alert if someone's trying to get out. Simple photo and info about a person. Here in Arizona, we have what is kind of the equivalent to an Amber Alert, but it's called a Silver Alert. And so we often see and we hear on the radio if there's a senior who has left the home and maybe not gotten back in a timely manner, and often we hear that the person may have dementia and have difficulty finding their way. But to know that you have a description of the car, what the license plate is, what their photo is, so everybody is alert to that. engage your team, whether it's your physician, your family, your community resources, your caregiver, in helping to advocate for you. Ask for what you need. Example, maybe initially when you're caring for somebody, getting a handicap parking tag. So if they can't walk very far, but you're concerned about leaving them at the front of the store to sit because you're not, and for you to then find a parking space, this way you don't have to do that. You can kind of both get close to the door and be with them the whole time, so that you're not risking their safety. These are some examples of some signage and some different kind of tools that can be purchased from a variety of different programs. The one on the bookcase is actually a giant kind of vinyl sticker that can be put over a door that may lead outside. It is a visual to be, oh, that's not a door, that's a bookcase, and people are then less likely to try to get out of that door. It's amazing how just a stop sign, which even for people who may not have total recognition of reading things, but a stop sign in both its color and its shape is something that most of us have grown up with, so we're very kind of tuned into that. So even in the later stages, a stop sign can often be the best protection against someone kind of leaving and wandering out. You know, we, again, are in a lucky place that there's so many different items that we can do to really think about the areas that someone struggles with and what we can do. You know, oftentimes individuals during some of the stages have a great fear of water. They don't want to go under the shower. Not a lot of understanding always why. But they do need to be clean. But instead of putting them through that, there's no rinse body products, that we don't have to have somebody go under the shower constantly. We can use more of a no rinse body and bath product. Adaptive clothing, so as it becomes more difficult to get in and out, or for someone who's taking their clothes off, maybe we do things where there's the buttons are in the back or the zippers in the back, so that it's less easy to get the clothes off and allows them to be in social settings without being inappropriate. Again, mobility devices, communication devices. I think it's important as we think about the stages that we also recognize that at some point hospice is an option for those who have a diagnosis of Alzheimer's and dementia. Hospice is a palliative program. All hospice care is palliative. Not all palliative care is hospice. The difference is that hospice is at a stage where there really is no longer treatment that's going to be provided. However, comfort is the key. As Dame Cicely Saunders, who is the founder of the first hospice in London, said that we matter to the last moment of our life, and we will do all we can, not only to help one die peacefully, but also to live until they die. And that's really what hospice is all about. Hospice keeps people at home, and home can be defined as one's personal residence, assisted living, a long-term care facility, hospice residence, and hospice comes to the individual needing care. It helps families and caregivers provide the care and be supported. It focuses on comfort. It helps patients and families retain control and dignity and understand what's happening. It provides bereavement support to patients and families before and after death and focuses on the needs of the whole person and family. And I think that's so key, particularly in an illness that lasts for so long, and there's so many ups and downs and twists and turns in terms of the emotions that people have to face, that support is so key. Hospice adds life to days when days can no longer be added to life. Grief and loss and the Alzheimer's client is different because families often experience it over such a protracted period of time. Grief in the early years is the loss of the presence of the person, while at death it's the person's presence that is lost. Grief is often complicated by Alzheimer's or dementia because the time alone has not afforded all the things that need to have been said or to have occurred. And oftentimes, by the time we recognize the magnitude of what we're facing, that individual may no longer be able to share those most important things that we all need and want to hear at someone's end of life. There are many resources for all of you. The Alzheimer's store has devices, and one of the things I really like is that they list them for early, mid, and later stage. So if you're not sure kind of the things that you may need in your home, they've really listed based on the different stages. MemView is a computer-based kind of, you can use a tablet way of doing activities and music for memory. Musicandmemory.org is another program that provides some great resources. Keeper Snow is an expert in Alzheimer's and has wonderful resources if you go to her website. The National Institute on Aging has a downloadable book called Caring for a Person with Alzheimer's Disease, and it really has such great information. It's over probably, over 100 plus pages, and just a really great resource to kind of put in a binder and review as you need. And then the Alzheimer's Association absolutely has so many resources, including finding support groups. I am so appreciative of having this opportunity to talk with all of you. Synergy HomeCare, again, is a national partner for the Alzheimer's Walk. It is our goal to end Alzheimer's, but in the meantime, as we continue having to research and learn more, to be a support for families who are dealing with this and to be a resource to provide care and support for the clients. If you have questions, please feel free to go to synergyhomecare.com. On that site, you can download, there's a free downloadable book called Where Do We Begin? A Guide to Elder Caregiving, which is 80-page guide on really for families to understand what's happening, what resources are available, home safety assessment tools, glossary, and tour forms, and just different forms that they can use as kind of their, almost a journal in a way of care. On our website, we also have many different resources. I am so grateful to be participating in this Longest Day series. We have one more session. This will be our fourth and last session that will be occurring at 4:30 Eastern Time, and that will be on advocating for yourself or others in the healthcare system, and really just knowing how to kind of be your best advocate when you're working in the healthcare arena. So again, please reach out if you have questions or comments. Please like our Facebook page, where we are constantly listing resources and an opportunity to be a community with different voices. So thank you again, and I look forward to seeing your name on the next webinar series at 4:30 this afternoon. Thank you so much.